I think we should get started. We got a lot of people on the line, which is great to see. I just want to start by welcoming everyone and thank you for joining us for our HIV Center rounds. We're very pleased that Chris Beyrer has agreed to do this. I want to give a special shout out to someone I see who's online, and that's Zena Stain. Welcome, Zena. It's so great that you're joining us. And I know you're probably on mute, and that's okay, but we just want you to know that we're very pleased that you're joining us today, along with everyone else who's online. Let me also remind everyone to keep themselves muted during this presentation, and also please put your questions. Actually, correct me if I'm wrong, and Stephen, you can jump in. Our preference would be to actually just put your name in the chat box, saying you'd like to ask a question. And then we'll keep you in the queue, keep you in order. So when we get to the Q&A, we can just go in order and you can ask your question then and take yourself off mute. How you'd like it, Stephen? Teo?
Correct.
Okay. So again, welcome to everyone. We hope that you and your loved ones are staying safe and healthy and as sane as possible through this crisis that we're living through. Glad that we're all in it together and we have support from each other. We do want to start with one announcement. I'm going to turn it over to Teo regarding our postdoctoral fellowships program and a couple of fellows. Teo, I'll turn it over to you before I introduce Chris.
Thank you, Bob. I think most people in the audience know that each time in June we have a big public event in the Department of Psychiatry and the New York State Psychiatric Institute where we celebrate the fellows and the residents who graduate from our programs. And it's always a fascinating event because you see the richness of the training programs that we have in the Department of Psychiatry and also the range of projects that our postdocs and residents engage in while they're with us. And of course, this year there will be no such event, and that is sad. But we do want to acknowledge that there are graduating fellows in our program, our training program in behavioral sciences and HIV infection. The first fellow who actually already left us is Ray Gannon. Ray came from us from the University of Florida. She had her Ph.D. in nursing. She was mentored while she was with us by Patrick Wilson. And while she was with us, it became very clear that she missed contact with patients. That was part of her training, part of her work before she came to us. She missed that, and she looked for opportunity to combine her academic work with contact with training with patients. And she found that opportunity in the School of Nursing at Columbia University, where she is now an assistant clinical professor. And she is also a link nurse affiliated with the New York Presbyterian Hospital and the Columbia Doctors Nurse Practitioner Group. And as such, she is, of course, involved in treating COVID patients, and the fellows in our program have heard her stories. And in a way, these stories are sad, but they are also uplifting to see the commitment of the people working there. So we wish Ray the best. She cannot be on this grad rounds this morning, but we wish her the best. And she knows that we're talking about her. The second fellow who is graduating, actually today is his last day in the program. Tomorrow he won't be a postdoc anymore, is Philip Truneski. He received his Ph.D. in developmental psychology from the Graduate Center at the City University of New York in 2016. He has been with us for 3 years, and he was mentored by John Santelli and Claude Mellons. His interest is, of course, as a developmental psychologist in adolescent development. And his research, while he was with us, focused on sub-Saharan Africa. He worked with John Santelli on the Rakai project in Uganda. While he was with us, he also was a lecturer in the Population and Family Health Department at Milman School of Public Health. Phil is waiting to hear about his successfully scored KO1 proposal, and we all have good hopes that he will be back formally as a member of our division, hopefully July. And in the meantime, he will continue to work with John Santelli and with me. And I hope that on behalf of everybody online, we can wish Phil success after his graduation and hope that everything goes the way he would like to. So congratulations, Phil, and congratulations, Ray.
Thank you, Theo. That was great. Congratulations to both Ray and Phil. And Phil, we're glad that you're with us today. We can see that you've joined along with some of your wonderful family members. So again, this is great, and we'll have a more formal event when we all can get back together. So I would like to move on to our event for today, and I'm just really very pleased to be able to introduce my good colleague and friend, Chris Beyrer. Chris is the inaugural Desmond Tutu Professor in Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health. He really is an expert across multiple domains as a professor of epidemiology, international health, health behavior and society, nursing and medicine, all at Johns Hopkins. He serves as the director of the Johns Hopkins Training Program in HIV epidemiology and prevention science, and as the founding director of the Center for Public Health and Human Rights. He's also the associate director of the Johns Hopkins Center for AIDS Research, their CFAR, and of the university's Center for Global Health. So you can really see the really breadth of expertise. Dr. Beyrer has extensive experience in conducting international collaborative research and has spent much of his career focusing on health and human rights. He was president of the International AIDS Society from 2014-2016 and was also elected to membership in the National Academy of Medicine in 2014. So he really is an international leader in the field. On a more personal note, I'd just like to say I have the good fortune of collaborating with Chris, the HPTN, first along with Theo Sanford and many others as part of the MSM's scientific committee, but also as I've been able to serve as co-chair with him on HPTN 078, which was focused on men who have sex with men living with HIV without viral suppression, and currently working with him on a new protocol in development, HPTN 096, along with our colleague LaRon Nelson at Yale University. HPTN 096 is focused on reducing HIV incidence among Black MSM in the southern United States. Chris, it's a pleasure to welcome you here today. I'd like everyone to join me in welcoming him and looking forward to his presentation titled, "Where is HIV Going? And why are we not achieving epidemic control?" Over to you, Chris, and thank you for being here.
Well, thanks so much, Bob, and good morning, everybody. Delighted to be here, and it's always a pleasure to really collaborate in any way with Bob Remien and with Theo Sanford. So I'm going to talk to you about some work that came out of actually a sabbatical that I did this past winter. Hopkins has 3-month mini sabbaticals. You're supposed to be able to take 3 months every 7 years. Almost nobody does, and it's a pity because it is an extraordinary opportunity. And so I spent 3 months, December, January, February, of this last year at the University of Cape Town at the Desmond Tutu HIV Research Center as a visiting professor, which was absolutely wonderful, and with a great group there led by Linda Gale Becker, who Dana knows well, and really an extraordinary group working very hard on what remains the largest and most lethal pandemic of our time. And of course, what is so easily overshadowed by what we're all living through with COVID-19 and its emergence and its devastating impact. But these months in South Africa really brought home to me the extraordinary levels, particularly of ongoing HIV incidence that we are seeing in a number of sub-Saharan African settings, but unfortunately also in the U.S., although I'm not going to talk so much about that, and many other places where key populations are at the center of the epidemic. And I was asked to give a keynote at the HVTN regional meeting, which was held in Cape Town in February, at the end of February. This is for the Vaccine Trial Network. Kind of reviewing the epidemiology, and the impetus for this, the reason for this, as many of you will know, is that the results of the large phase 3 efficacy trial of the most recent HIV vaccine, HVTN 702, which was a kind of bespoke, if you will, vaccine that had been really developed based on the only successful trial in the past, which was the RB144, but adapted to South Africa and with a clade C insert. And so there was a great deal of enthusiasm for this product, and there was a very large and well-conducted trial. Linda Gale Becker was one of the leaders, along with Glenda Gray, and it showed no impact at all. So I'm going to show you those data, and it was an enormous disappointment. But really, it also was an opportunity for us to look at something quite extraordinary, which was the incidence density. So I'm going to talk mostly about published studies and recent studies, 702 highlighting as well, but also some other work, including Teo's work, all of which is really to help us ask the question, why are we seeing the incidence densities in HIV that we are still seeing, and why has the benefit of treatment as a preventive intervention not delivered as much as we want to see at the population level, in contrast to the extraordinary outcomes we see at the individual level? So let's jump into this, and you'll understand more about what I'm talking about. First, next slide is my disclosures. So just to say, I have NIH funding from a number of institutes. Some of this work was funded by AMFAR, Elton John. ViiV Healthcare, we're evaluating a project of theirs in Baltimore and Jackson, Mississippi. And Gilead has donated Truvada for a PrEP trial that we have with young MSM at risk in Bangkok. Next slide. So this is from ABAC's most recent report, and it was, of course, looking ahead to 2020. Many of you will know that 2020 was supposed to be the watershed year. We had many goals aimed at 2020, as we have had for 2030. And the prediction was that by now we would be seeing major declines in HIV incidence. And unfortunately, of course, that's not what we're seeing. And I think the message here from ABAC that widespread treatment is essential, but it isn't enough, really is in a way the bottom line for this talk. And the fundamental here is that primary prevention is where we are not meeting our fundamental goals. We have enormous challenges with primary prevention. Next slide. Yeah. So here are some of the critical challenges, and I just want to begin with these because I think this will help shape our looking at these data together. So, of course, we have had incredible advances in treatment and in treatment access between national country efforts, the PEPFAR program, Global Fund, and in the U.S. with Ryan White, and with the ACA. It really has been extraordinary how many more people are on treatment, now the majority of people worldwide. But incidence, particularly in women and girls in Eastern and Southern Africa and in key populations pretty much everywhere, remains too high for epidemic control. So I'm going to talk about the ECHO contraceptive trial and HVTN 702, and both of which I think will demonstrate precisely what we're talking about. We also have to look at the findings of some of the big treatment as prevention trials or universal test and treat, all of which have consistently shown important clinical benefits and improvements in clinical outcomes, including in chronic diseases and in tuberculosis, which are incredibly heartening, but none of which have demonstrated the kinds of incidence declines that we want to see. And just to say that recent CDC assessment 2010 to 2015, this has been updated, suggests that the U.S. epidemic has been declining at only 2% per year. That is much too slow, again, to achieve epidemic control in this country. Next. Yeah. So let's talk about women and girls, which when you are working in Cape Town and in South Africa, is an inescapable part of the epidemic, because so much of the research, prevention, and control effort that is happening for women and girls worldwide is happening in Southern and Eastern Africa. And that, of course, is a function of the incidence, but also of these vibrant, young, dynamic communities. This is actually a mural painted on the side wall of a clinic for young women and girls at one of Desmond Tutu HIV research sites. I thought that kind of captured beautifully the dynamism that we're talking about. Next slide. So the first big trial to talk about is the ECHO trial, and this is the evidence for contraceptive options. The impetus here, as many will know, is that there have been repeated suggestions from epidemiologic data suggesting that some forms of hormonal contraception, particularly Depo-Provera, injectable hormonal contraception, might be increasing women and girls, particularly younger women and girls, acquisition risks for HIV. So there was an attempt to really say, okay, we need a definitive study in which we will essentially compare, randomize and compare the standard contraceptive options for women and girls and look and see if there are differences in HIV acquisition. Next, please. So this is the study. It was published in The Lancet in July of last year. A distinguished group of investigators, including many of our friends and colleagues, the HPTN and others, Linda Gale Becker, and it compared basically the intramuscular depot hormonal contraception, an IUD, intrauterine device, or an implant for contraception, randomized, multi-center, open-label trial. Next slide. So just first to say that if you look at the unmet need for contraception, and this again is from a presentation from Helen Reese, one of the PIs of this study, it jumps out at you that the unmet need for contraception is remarkably high in sub-Saharan Africa. So that is really a challenge. Next. These are the sites, so Kenya, Zambia, South Africa, and Eswatini. And I would just say, before we jump into the incidence data, that these, of course, are all countries that have had massive PEPFAR investments in the many billions of dollars, including Global Fund investments and their own country investments, including South Africa, which now has the largest HIV treatment program worldwide. And of course, the world's largest HIV epidemic. But these are all countries in which there has been an extraordinary investment in testing, treatment access, and with, by the way, also programs with significant focus on young women and girls. Kenya and South Africa, of course, being the leading ones that have really tried to do PrEP and bring PrEP to women and other populations at some scale. Next. So it's an interesting screening and eligibility from an epi perspective, and I would just highlight the statement at the bottom that women were recruited for this trial based on residing in geographies that had high risk of HIV, but not individual characteristics. So this is not an attempt to identify high-risk women, sex workers, women with a history of STI, or any of those sort of classical high-risk enrollment criteria. These are women who are of reproductive age, who are not pregnant, who desire effective contraception, are HIV uninfected, and agreed to use whatever method they were randomized to for 18 months, and they're 16 to 35-year-olds. So keep that in mind. This is a kind of general population of young, reproductive age adult women not screened for risk, for high risk. Next. And here's the finding, and this is really great news, right? What you want to see is that none of these different forms of contraception are increasing women's acquisition risks. So there is some slight variation, but the curves really hold together. DMPA, a copper IUD, and the implant don't really look very different, happily. Unfortunately, as you will see, there is nevertheless significant HIV acquisition in this population. So if we go on, and everybody should be celebrating that, by the way, that is a great outcome. But here's the downside. The downside is that the overall HIV infection rate in these women was 3.8 per 100 person years, with a range, a 95% confidence interval of about 3.5 to 4.2. Now that is not different from the HIV incidence in these populations when I was involved in 2001 and 2002 in doing site expansion for the HVTN and brought a number of these sites into the vaccine trial. And that is just extraordinary, that close to 20 years on, and remember at that time there was essentially no effective therapy. PEPFAR did not begin until 2003. There was very little treatment going on in sub-Saharan Africa. Now we're over 60% of people living with the virus on treatment, and here we are with women, general population of reproductive age, women not screened for risk, and still over 3.8 per 100 person years. Now, if you take that out over time and you look at the lifetime acquisition probability for a woman in this population with over 3% incidence per year, it's well over a third. And that's, in fact, exactly what we see in these countries, particularly in the Southern African countries. So that is why this is, I think, pretty hard empirical data that we are a long ways from epidemic control. So let's move on. Just to say a few things about the women in this study, because I think it's relevant for thinking about this challenge. First of all, they were largely young. The median age was 23, and the majority were under 25 years of age. So that really is the group that we're looking to find, right? Most were not married. Over 80% are unmarried, and most had been pregnant before. So, you know, the thinking that's out there that, for example, marriage is such a significant risk for acquisition for women, that may be true, but the majority of these women are unmarried, young, sexually active women looking for contraception. Condom use was spotty, STIs were common, and there was clear that some people had been using other forms of contraception. Let's go on to the next slide. So this is from their paper, actually, the discussion of incidence. Despite an individualized HIV prevention package provided to all throughout follow-up and countrywide HIV treatment and prevention, incidence was alarmingly high. STI prevalence at baseline also very high. And what they came away with was saying that this strongly emphasizes the need for more aggressive HIV and STI prevention for African women, including PrEP and HIV prevention integrated into contraceptive services. But of course, they had integrated HIV into contraceptive services to do this study. So it's in a sense a call to do more of the same and maybe to do some more PrEP. But of course, it isn't really clear that daily oral PrEP is going to be the kind of effective prevention tool that will make a difference. So this leaves us, I think, in a pretty challenging place. Next slide. So let's talk about HVTN 702. 702, as I said, was an attempt to build a prime boost vaccine strategy based on the RB144 in Thailand for Southern Africa with a clade C specific insert into the same prime boost vaccine backbone. Next slide. And here are the incidence data comparing vaccine and placebo. So the vaccine arm of the study, several thousand people, is there in red. The placebo is in blue. And the really tragic outcome for this trial, even though it was well done and it had a clear answer. So, we call this a successful trial because you can interpret the results. The vaccine is not, however, successful. These curves never differed, and there's absolutely no vaccine impact. And the trial was, in fact, stopped early for futility. Not for harm, happily, no evidence of enhanced immunity, but certainly no evidence for efficacy. Next slide. Now, here are these same data, but broken out now by gender, sex assigned at birth. So looking at 2 years, and you can see that persons who are assigned male sex at birth have a significantly lower incidence. Vaccine and placebo look the same. It's a little over 1. Both of those confidence intervals wrap around less than 1. But look at the women. All right? So again, no difference in the vaccine and the placebo in persons assigned female sex at birth, but an incidence over 4. And this is even higher. And this is more current data. This trial was just stopped in January when I was in South Africa. Let me tell you, it was a gloomy afternoon. But nevertheless, the incidence is so striking. So it's over 4 per 100 person years, untouched by the vaccine, but really very striking. Next slide. So how do we explain this? How do we understand, and by the way, all of the 702 sites were in South Africa, and it was well over 5,000 study participants. So, of course, South Africa has, as I said, the world's largest treatment program, and yet we're seeing this sustained levels of new infection. How do you square that with, for example, the very exciting data that we have seen from early studies like HPTN-052, which showed in discordant couples the great success of treatment as prevention, and the partners studies in Partners 2 that essentially showed 0 transmission between discordant couples, both heterosexual and male same-sex couples, with treatment. And I think this paper, led by Steph Barral, fantastic epidemiologist in our group, and a number of his colleagues, really tried to unpack this disconnect. And the disconnect is between the individual level benefits of treatment as prevention and the population level HIV prevention benefits of antiviral therapy, which are not the same. So next slide, please. So here you have on your right in blue the HIV incidence outcomes from 3 large treatment as prevention trials that all attempted in various ways to do combination treatment and prevention at population levels and to use antiviral therapy to reduce incidence at population levels. The first of those to be reported was the South African French ANRS trial, and as you can see, the confidence intervals there broke. There is essentially no impact on incidence of that study. Search, wonderfully done study in Kenya and Uganda, led by Moses Kamya and Diane Havlier, same thing, wrapping around the unity variable there and no impact. HPTN-071 has been complex to understand. It had varying arms, but if we look at what they said they were going to compare in the treatment arms across that study, they also did not see a significant reduction at population levels. So those 3 did not work at all. Contrast that with HPTN-2 on your left, a dramatic reduction in HIV transmission in discordant couples. Discordant couples, of course, are not the same as population samples. Hold on to that thought. The START trial, which showed the tremendous impact and reduction of mortality from early treatment. There's no question about the clinical benefits of earlier initiation. Temprano showing the same thing. So here we have encouraging results at the individual level, encouraging results at the level of the dyad, of the couple, and then a failure to show efficacy for reducing incidence with treatment at the population level. Next slide. So I'm going to, and this is also from their paper, looking now at several other African countries that have done well with the treatment rollout. What you're looking at there in red is the coverage of people receiving ART. It's over the 2010 to 2017 timeframe, and you have Botswana, Rwanda, and Ethiopia, all three countries doing very well with increasing treatment. And then in blue is new HIV infections, and you can see one somewhat declining in Rwanda, flat in Botswana, and rising in Ethiopia. So again, evidence of this disconnect between the benefits of treatment, for which there is no question, and the reductions in incidence, for which the evidence is not looking compelling. Next. So let's talk about why we think that is. And I've pondered this a lot and looked at the data, and I think there's a number of things we can say that will help us really understand what's going on here. So first is that transmission is relatively early in disease course, and treatment initiation remains late. So there's a time lag here that is very, very different. And when we particularly look at men, you will see it's very striking that we have had very little change in the CD4 initiation in men across Africa and Asia. In other words, men are continuing to present late in disease course, and most of whatever transmission history they are going to have is behind them by the time they get onto ARVs. Next. There is also just the reality, it's a core epidemiologic principle, that prevalence drives incidence, the force of infection. And so when you get up to, as South Africa has, and Eswatini and Botswana, over 20% prevalence in populations, it becomes enormously hard to reduce new infections. The prevalence is just so high. It's also true that the testing and treatment infrastructure across much of the developing world was built on maternal-child health platforms and built around programs for women and infants, child survival, immunizations, and that whole effort, which has, of course, saved enormous numbers of lives. But that is not a platform that is built for men or welcoming for men or convenient for men, and that remains a very big challenge. And you will see again and again, both sides on programs for women and girls that don't include men and don't make space for men. And of course, in the predominantly heterosexual epidemics, that is clearly insufficient. Men not only present late, they also present with a lower median CD4 than women. This is true across Africa and across Asia. We did an assessment of gender for WHO, the largest systematic review my group has ever done. And it was really very striking that there was higher mortality at a year after diagnosis for men compared to women, and at 5 years. It didn't budge over time. This also, we think, is largely a function of late presentation and of men essentially showing up for clinical care when they're too sick to work. This was true across sub-Saharan Africa, but it actually was even more marked in Asia, where a significantly larger proportion of men are IDUs and people who inject drugs and have higher non-AIDS mortality in addition to AIDS mortality. Next point. So I would also argue that, remarkably enough, in 2020, the risks, particularly for women and girls, are heterogeneous and poorly understood. These trials are enrolling women who would not meet most of our high-risk criteria, and yet well over 3% in some, in 702, over 4% of them are still acquiring HIV every year. So we have still epidemiologic work to do in understanding who's at risk and why, and what interventions might make a difference for them. And the last point, data, of course, on those most at risk is still limited. And we're going to now go into talking about key populations and where the data are really quite spotty in many places. And finally, I would say that we do have course. One, clear intervention with benefit for men, for women, for people who inject drugs, for people who use it as prescribed, and that is oral PrEP with Truvada, and for men with Descovy. But the use is just still too low to really be impacting incidence. And let me show you precisely what I mean there. Next slide. This is from Rachel Bagley at WHO. It's from mid-year last year, 2019. It's the total global number of people thought to be on pre-exposure prophylaxis. It's still under 500,000 by the middle of last year. And the bulk of those people are in North America, actually the United States. So that big blue chunk there is the US. If you take that out, the reality is that the era of PrEP uptake and use and implementation as a prevention tool hasn't started by 2019. Folks will remember that the first trials that showed that this worked were in 2010, 2011. So there's been a very long lag time in implementing this intervention. So let's now talk about key populations. And I would say this part of the talk was made a little bit more painful for me personally. Is while I was in South Africa, a young pop star, Linda Kule-Sele, an LGBT activist and musician, was brutally murdered, broad daylight, at a market in Durban, actually, just 22 years old. And it underscored that even though South Africa is the only country on the continent with full civil liberties and rights for LGBTQ people, it remains a dangerous place to be gay, particularly in some of the township communities. This happened in a township outside of Durban. Next slide. So our group has defined key populations as really sharing two characteristics, and I think this is a helpful way to understand this. So these are individuals and communities who have disproportionate burdens of HIV risk and disease. So there's the disproportionate burden component and lack of access to essential services. So if you have both a high burden and less likelihood of accessing essential services, that puts you in this key populations category. And pretty much that means people who use drugs or inject drugs of all genders, sex workers of all genders, gay, bisexual, and other MSM, trans women who have sex with men, and prisoners and detainees. And in Eastern and Southern Africa, women and girls, and of course the uninfected partners, HIV uninfected partners, and folks in discordant couples, including discordant couples with some key populations partners, and adolescents from all of these communities who consistently have the highest acquisition rates and risks. Next slide. So the epidemic is changing, of course, and even though our focus up till now has been on Southern and Eastern Africa and that enormous epidemic, when we look globally, we crossed a milestone last year with more than half of new infections being in key populations. The overwhelming majority in Eastern Europe and Central Asia. Just keep going through these. Yeah, the overwhelming majority in the Middle East and North Africa, Western, Central Europe, and North America. But I would just point out also the majority of infections in Western and Central Africa, many of those among sex workers, and now about a quarter of new infections in Eastern and Southern Africa. So key populations matter everywhere. They are the majority of folks now at risk for HIV in most of the world. And they, of course, play very important components in the epidemics, even in the most affected general population epidemics. Next slide. So I thought I would share with you some data from South Africa, again, on key populations. This is from TB HIV Care, wonderful organization, PEPFAR implementer, with a number of partners, including Innova Health, out South Africa, an LGBT group, and others. And they were doing a national survey, actually, to look for hepatitis C in key populations in South Africa, but it's a quite large data set that also includes HIV. So I think very relevant for our conversation this morning. Next slide. I won't go into all the detail, but just to say it's a robust national sample, and they looked at MSM, sex workers, and drug users across multiple sites across South Africa. Next slide. And there are a number of important findings here. Again, I won't go into all the details, but just to say that, for example, among people who inject drugs, the great majority were men, and 2/3 of them were unstably housed. So an extraordinarily high-risk group. Next slide. And here are the outcomes, including hepatitis B, Hep C, and HIV across these populations. Hep B, pretty standard, relatively low rates. HCV, not surprisingly, much higher in people who inject drugs. But look at these HIV burdens. So almost half of the sex workers, 43% of MSM, 21% of people who inject drugs, and 13% of people who use, these are non-injectors, mostly using stimulants, amphetamine-like substances. Just extraordinarily high burdens of disease. Next slide. They also did some qualitative work around this, trying to get a handle, for example, on stigma and experiences of stigma in these populations. Drug users in particular having very negative reactions with healthcare workers. When the doctor heard I was using drugs, he went off. It was the worst experience I've ever had with a doctor, and very low levels of successful linkage to care. Next slide. So we also wanted to look at one of these key populations, particularly MSM. This is a Sibanye Health Project in South Africa. Linda Gale, myself, Patrick Sullivan, some others. Next slide. And Sibanye screened in total about 300 township men who have sex with men. We found an extraordinary burden of infection, about 43% overall across the two cities, and a significant proportion of these infections were in men who had not been previously diagnosed. Next. And when we look at that burden, I mean, it's just really, really so striking. You see that it's already incredibly high even in the youngest age group. So 18 to 19-year-olds, the prevalence was 35%. So we are really going to have to go down in age with prevention to have an impact on this component of the epidemic. Next slide. This is what the continuum of care looked like for men living with their diagnosis. As we said, about half of these were previously undiagnosed. So it's an unimpressive first 90, according to the UN 90-90-90. A little bit better in terms of accessing care and currently on ART, but with 15% or so undetectable viral load, this virtually assures ongoing transmission in these networks. Next slide. On the PrEP uptake and continuum, things looked a little bit better among the HIV uninfected men, and we had a significant interest in PrEP and significant uptake, so that's really very encouraging. This was actually the first study that was able to get PrEP approved and available for MSM in South Africa, and so we're really heartened by these findings. Next. But unfortunately, the incidence overall was over 6 per 100 person years, so extraordinarily high. And most of those infections, the numbers are small, but nevertheless were clustered in the youngest age group, double-digit incidence in 18 and 19-year-olds. So an extraordinarily hot epidemic in epidemiologic terms. Next slide. Now, I had said to you that I would share some data from HPTN-075. This was a study led by Teo Sanford and his colleagues for the HPTN. And this was an attempt to look at cohort feasibility across 4 sub-Saharan African sites for MSM. And overall, enrolled about 330 uninfected men. You can see some of the characteristics of this population here. It's quite a young group. Actually about the same age, median age, as the women in the contraceptive trial. pretty high rates of risk behavior, and 16% or so having a rectal STI at enrollment, which is really quite extraordinary, somewhat of a marker of lack of access to healthcare. Next slide. So this trial, or this study too, unfortunately identified a very high rate of seroconversion, over 6, closer to 7, with a range of between 4 and 10. So that's very consistent with the data you've just seen from the Sibanye project, and it again suggests just an extraordinarily high level of HIV acquisition. Next slide. These are the data by site. Again, small numbers, but nevertheless, you can see that South Africa really jumps out, and Cape Town in particular. Just heartbreaking, considering also that South Africa, as we said, has marriage equality for LGBT folks, has on paper anyway, the Constitution very supportive of LGBT rights, but clearly an epidemic in MSM that is out of control. Next slide. So I think we can skip that. I think we've kind of made the point about risk behaviors and the fact that Cape Town unfortunately jumps out as being really the highest incidence density place. Next slide. So I just want to say, and that's all the data I'm going to show. This is an updated AVAC slide. Many of you will be familiar with this, with all the preventive options that are out there. We are and have been for a while on the cusp of a whole range of new potential interventions that will take us beyond oral PrEP, which for now is really the only other tool we have besides treatment, behavior change, condoms, STI treatment, and the like. And we're really, all, I think, enormously enthusiastic about long-acting, about injectables, the potential anyway for broadly neutralizing antibodies to have a big impact. We still have some vaccine trials in the field with new candidates, and 30 years on, that effort is still ongoing. But I think what the data I've tried to show you today suggests is that without advances in primary prevention for women and girls in sub-Saharan Africa and for key populations everywhere, we are still not on an epidemic trajectory for success with this pandemic. And I think that is extremely important. We constantly have this rhetoric out there about the end of AIDS, about getting control of the HIV pandemic. And after 30 years of work in this field, there's nothing I would rather say to you than that we are winning. But I'm afraid we have some real challenges ahead, as I've tried to describe today. Maybe go on to the last slide. So, a couple of summary points to make. First of all, incidence densities are too high to achieve epidemic control, both in sub-Saharan Africa and in key populations. These incidence densities in women, I think, really say that primary prevention is essential and treatment is necessary but insufficient. And that's a very important message, because there's an awful lot of ministers of health and national AIDS program managers out there who think if they meet the 90-90-90s for treatment, they are done. And that is not what these data are suggesting at all. The low engagement of men in testing and prevention and in the treatment continuum is an ongoing challenge, and we have got to focus on research, implementation, programming, and health systems for men at risk. And I would argue that HIV in key populations really remains the work done in the HIV response. And that is really the impetus behind this next big domestic project that Bob alluded to in his introduction, that we really have to focus on in the U.S. as well, where we primarily have a key populations epidemic, overwhelmingly in MSM and particularly in minority MSM. That is our work undone in this area. Next slide. So I just want to thank a number of folks, and Theo, I didn't get you on here, but I also want to thank you for the 075 slide. Harry Hausler heads up the TB HIV program. Patrick with the head of Sibanye, Patrick Sullivan, 702 slides from Linda Gale and Glenda Gray, and then my own group in the Center for Public Health and Human Rights at Johns Hopkins. So thank you for your attention, and I think we have some time for questions. Sorry to be so sobering, but I hope I've convinced you that, particularly for the younger folks who are out there and who are contemplating a career in HIV, we have a lot of work to do. Please stay with us.
Thank you so much, Chris. Yeah. Applause. As always, that was such a tour de force. Very well thought out and really important data that you pulled together and presented. So we really appreciate it. And we do have time for questions, comments, and discussion. So please, let's start that.
We just jump in?
Yeah, please.
Hi, Chris. Sam Friedman here.
Hey, Sam.
Hey, really wonderful talk. Just depressing as I've been reading the data. We have developed, as some other people, various interventions to start from newly infected people, trace their networks, and intervene quickly. And we've got some preliminary data from South Africa suggesting that we're able to recruit men using these techniques. We're also having a hell of a problem getting NIH to fund us, which, we're going to take your talk and make good use of it when we resubmit. What are your thoughts about these kinds of network interventions?
Well, I think, we now know very clearly that both HIV and STIs are transmitted through networks, and network level functions really matter. And I think particularly when you think about prevalence driving incidence and the force of infection, that the network level functions are very essential. Because whether or not you are in a high transmission network has a huge impact on whether or not you're going to acquire HIV, irregardless of your own level of risk. So, Greg Millett did really elegant work on this almost a decade ago now, in 2012, looking at African American men, and the single most important risk for acquisition for them was being in networks of other Black MSM, right? Lower individual and couple level risks than white men, 5 times the HIV prevalence. So there's no question that we know epidemiologically how important networks are. I think the challenge consistently has been how do you intervene on a network level? There's a lot of enthusiasm at the NIH and at the CDC. It's one of the pillars of the new Ending the Epidemic initiative, is this idea of advances in molecular epidemiology. I didn't get into that in this talk at all, but the kind of cluster busting idea that you could use phylogeny to identify these networks, and that would, sharpen our ability to intervene at network levels. I think it's fair to say that the jury is out. There's no question that the molecular tools are better, but how they're going to work with contact tracing and shoe leather epidemiology and doing the kinds of work that it takes to assess the network and do something about it in real time, we just don't know yet. When I gave this similar talk at the HVTN in Cape Town, Susan Buckbinder, wonderful epidemiologist, prevention scientist who we know in San Francisco, came to talk with me afterwards. And she said, we tried cluster busting in San Francisco, and it didn't really improve on our standard approaches. I will say that just from a purely epidemiologic and viral load perspective, that the earlier you intervene, particularly with men, and get people virus suppressed, the more you can shorten the period of infectivity, that is eventually going to have a big impact. So I think you're absolutely on the right track there.
And we've shown that working with people with drugs primarily, so not only if you catch them early in infection and trace their network, that seems to be a good program that works. Recent paper by Vassilieva in viruses is one of the more recent papers on that.
Mm-hmm. Mm-hmm. I will say, you know, that and Bob might want to comment that we've looked at this as a possibility for 096, but in the United States, and in particular in some of the most affected states where we're working, the laws on non-disclosure and criminalization of transmission, which have been predominantly aimed at minority populations, make the community incredibly anxious about this. And so we have opted not to use the molecular tools, although we certainly are going to try and be, working at network levels. But that's a cautionary note that is just a reality. We've been involved in, when I was leading IAS, we got very involved in work around trying to address and reduce this criminalization of transmission. But the laws lag way behind the science. They always did, but now they're even more out of date.
Yeah, thanks for that, Chris. I was going to add that same level of complexity. We've heard that not just in the U.S. but in global settings about a lot of community mistrust about that approach, unfortunately, because of the laws, as you mentioned.
Great. We have another question from Christina, and then a follow-up by Natalie. Much of what was presented is on what's not working. Can you please expand on what does work if we're doing primary prevention correctly in order to impact population-level incidence in the U.S. and global context? And then Natalie's follow-up is, can you describe the primary prevention efforts aimed at reaching adolescents?
Yeah, both really important questions. Well, the first thing to say, and I'm sorry if I made it sound too on the negative, but we have had real success in controlling HIV in a number of settings, and probably, and it's a real frustration for Sam and myself. They're probably nowhere more true than among people who inject drugs, where we have an essential primary prevention package that includes harm reduction, needle and syringe exchange, drug treatment on demand, antiviral therapy for drug users living with the virus, and a number of other elements, hepatitis screening, STI treatment. But essentially, if you put those three pillars in place of needle and syringe exchange, drug treatment on demand for opioid dependence, and ARV treatment for people who inject drugs living with the virus, you can get very rapid control of HIV transmission in these populations, and you can bring incidence down. The first place to do it was New York City, so right where you are, but any other municipalities have achieved this, and those successes have been sustained in many settings. So primary prevention for that population really does work. It's just proven politically challenging in place after place. And unfortunately, in much of the world, we see people who inject drugs remain the most at-risk group. Eastern Europe and Central Asia, South and Southeast Asia, East Asia, and so that is an enormous frustration. But nevertheless, primary prevention really works there. There are good data emerging from a number of settings for men who have sex with men that if you both get high levels of treatment, so that's testing and treatment, and get to a critical level, it's probably over 20%, maybe somewhere between 20 and 30% of at-risk men, not infected, but at risk for acquisition on PrEP, that you can dramatically bring down new infections in men who have sex with men. So New South Wales, the data in Australia, you want to take a look at that. It's very compelling. The UK data, when they finally rolled out PrEP, they had a sustained epidemic in MSM for years, despite high treatment coverage, but with treatment and PrEP, really seen dramatic reductions. San Francisco. So there is no question that primary prevention really can work. In that case, it's a combination, of course, of primary and secondary, because you're also using treatment. I think for women in sub-Saharan Africa, and particularly in southern Africa, where the incidence densities are highest, the big challenge has been that the one powerful primary prevention we've been able to add, which is PrEP, is turning out to be an uptake challenge and an adherence challenge. And so we need to do a great deal more work on primary prevention tools for women. And I think that that's why there's been such sustained enthusiasm for topical products, despite disappointing trial results, and now real hope around injectables, depot formulations, long-acting formulations. And the HPTN is going to embark now on what are called dual-purpose technologies, where we might, for example, look at a Depo-Provera depot contraceptive with a long-acting PrEP element, such that you might be able to do contraception and HIV prevention in one go, one-stop shopping, and that would be, we think, enormously appealing to users. So there's a lot of work in that space, but there's also a lot of evidence that, you know, we can achieve success.
Thanks, Chris. We have a question from Teo.
Oh, good.
Thanks. It was a great talk. You stressed the important position of key populations in Western Africa, but also in South Africa. And when you present that, it's as if the key populations are separate from the so-called general population. But when you look at men who have sex with men in African countries, we always observe that a huge proportion of these men are men who also have sex with women. Compared to the United States, it's much more. And there are a lot of reasons for that, of course. So I would like you to comment a little bit on how the key populations are part of the general populations and what that means in terms of the spread of HIV. And there are probably a lot of things that we don't know yet, but I'm curious to hear your thoughts.
Yeah. Well, I think that is true. We should be clear that with the West and Central African key populations, a substantial proportion, I think actually the majority in most of those countries, are women sex workers. So that is certainly the case in Senegal, Ghana, Nigeria. So, you know, when you talk about key populations there, that's a big part of it. And of course, who are the clients of those people, right? Overwhelmingly, they are sexually active men of reproductive age. So it's absolutely the case that they are not somehow hived off or distinct from the rest of the population. But it is also true that they have different prevention needs often, and they have, of course, differential access to services. So, for example, I was involved for a number of years with a sex worker program in Tanzania. And, you know, what we saw, which was really very in rural Tanzania, in Iringa district, which was enormously challenging, was that, you know, the women running the clinics and services for women, so providing contraception, STI care, HIV services, testing, so forth. There wasn't PrEP at the time, but there was treatment. Very actively discriminated against women they perceived to be sex workers. You are not welcome here. We saw you working in that bar. You know, we know you're a loose woman. This is a clinic for married women, virtuous women, for mothers and children. You don't belong in this kind of setting. And by the way, giving the same messaging to pregnant adolescents who are unmarried. You shouldn't be here. You shouldn't be pregnant. You shouldn't need these services. actually have documentation of signs in clinics, handwritten signs saying, bar girls not welcome or other forms. And these are in places where there are truck routes and there were large numbers of sex workers, and they really were very systematically excluded from services. So it is epidemiologically true that they are not distinct from the populations they're operating in. Quite the opposite. They're very connected in terms of sexual networks and risks. But they are excluded from many community aspects, and I'm sure you know that and have seen it with MSM. And that presents particular challenges. Tanzania decided with PEPFAR, it actually was much of a PEPFAR decision, that they would set up a separate clinical service for key populations. They set up 30. They stood up 30 of these clinics across the country that were really aimed at sex workers and MSM. And then there was a change of government, and a conservative government came to power and made a political point about how unacceptable this was culturally, and all of those clinics have been shut down. They have not been reopened, and those people have lost whatever specific access to services they had. So I think we have to be, kind of sophisticated about the ways in which the virus is being transmitted in these networks, which is absolutely happening, but also the way that people remain socially excluded and marginalized. That is a very challenging combination. And I think we still have a lot of work to go figuring out, for example, in the township concept in South Africa, where you have far and away your highest rates of infection, how do we provide meaningful services for people who are in communities where they, risk physical violence just being who they are, just being in public. I mean, we have, stigma data that people are literally afraid to go to the market, and they're right. They are right to be afraid.
Thanks, Chris. It's very, very helpful. Thanks.
Next, we have a question from Victoria Fry, who's from the CUNY School of Medicine. In your view, what are the most important approaches to working with men who have sex with women in Southern Africa that are missing or have not been tried?
Yeah. So I think that's very important. I would point you to the SEARCH data, the SEARCH trial. This was the large treatment as prevention in Uganda. Among the big studies, they did the best with engagement of men. Unfortunately, HPTN-071 did the worst, and many people believe that the reason it didn't show more in terms of incidence was because of low engagement of men. So there are a couple of things that SEARCH did right that I think are very important models. One is they did formative work up front about where men would be willing and interested to seek both HIV testing and screening for other diseases, and what they actually were interested in. So it emerged very quickly that men basically see their role as providers for their families as fundamental, as the most important thing. Most of them cannot afford to take days off from work. They don't want clinic hours during working hours. They want work-based programs where they could either at the end of a shift or during a lunch break, be able to access a quick service. They were much more interested in screening for hypertension and diabetes, which are much less stigmatized diseases than they were in HIV. They were interested in mobile services that were not in the home, so they could get an HIV test without the household approach. Many of these treatment as prevention trials have done household testing, where you miss men because they're not home during the day. And so those kind of really operational issues, where are men, how do you reach them, how do you provide them with something they want, the evidence is really very good. And SEARCH had a spectacular increase in male engagement with work-based screening, with providing hypertension and diabetes screening, and with the use of mobile vans and mobile services. So it can be done, but if you are in busy MCH clinics with lots and lots of crying babies during workman's hours, you are not going to get, you're not going to attract men and engage them in meaningful numbers.
Thanks, Chris. We have a question from Phil Kranitsky. How does mobility within and across nations factor into some of the results for key populations you presented? And do you have thoughts about how mobility might be related to accessing prevention and related services?
Yeah. Well, it's not just key populations. It's a very good question. So the thinking about search, one of the reasons that the search trial did not show declines in incidence, it looked better in some communities than in others, and it really fell apart in Western Uganda. And there it actually flipped, and it looked like it was harmful. And in a post hoc analysis, so, you know, you have to be a little ginger about post hoc analyses, but anyway, in a post hoc analysis, it appeared that there was significant in-migration because of conflict in DR Congo, and there was a significant increase in incidence due to an HIV incidence due to that in-migration, and that probably washed out the effects of the intervention. So mobility does play an important role. The ANRS trial, that also was done mostly in KwaZulu-Natal. KwaZulu-Natal is, of course, on the far eastern coast of Southern Africa. It's the Zulu area, and it has the highest burdens of HIV worldwide in any community, and very high rates of labor migration for men and for women. So, you know, that's been, we've known about that for many years. I think one of the things that has emerged in a couple of studies, and Elvin Gang has really led this work. He was at UCSF, he's left now, but he did some really elegant implementation science work about the issue of mobility, loss to follow-up, and mortality, trying to understand those relationships, again, mostly looking at Kenya and Uganda. And what he found was that many of the people lost to follow-up in antiviral treatment services were not dead, but had moved and had engaged elsewhere in care and other program areas. So that actually was encouraging. But what we don't have, of course, are transnational databases to do this. He added ad hoc onto implementation science. For key populations, the mobility of sex workers in particular is very high, and the transnational mobility is high, and they often are excluded, explicitly excluded from services. So I'll give you an example. My Thai R01, which is looking at effectiveness and cost effectiveness of PrEP among young Thai men who sell sex. So it's the largest sex worker cohort of PrEP study that we know of for men. The majority of men selling sex in Bangkok are non-Thai. They are mostly from Burma, Myanmar, and from Cambodia, with some Lao and a few other Filipinos and other nationalities. But the bulk of them are Burmese and Cambodian. The national IRB would not allow us to enroll non-Thais. So we were only able to enroll the minority population. And that's just an example of how, you know, non-resident or extra-national undocumented foreign sex workers get completely excluded from services. And, you know, it's their country, so you have to go along with that. But I think from a public health perspective, that just, you know, ensures that there's going to be ongoing transmission because you're excluding the riskiest people. And that kind of structural challenge, you know, just continues to bedevil us.
Thank you, Chris. I think we have time for one more question. So if you do have a question, please indicate so in the chat. Otherwise, I'll hand it over to Bob.
Well, yeah, thanks. But I also see that there was, I think you touched upon it, Chris, but there was a question earlier that invited you to expand a little bit more on your thoughts about the primary prevention needs for adolescents in particular.
Yeah. Well, talk about structural challenges. I think the issue so often for us with adolescents, and it obviously it varies by country, is that in many settings, the U.S. is a good example. They have mixed level of autonomy and freedom to make choices. So they're engaging in acquisition risks. You saw those data that I showed you that really the highest for MSM and for women and girls is in the youngest categories. But all kinds of challenges with being able to provide the services they need. So primary prevention, would start, for example, with meaningful evidence-based sexual health education and risk reduction. That's very hard to deliver, but nevertheless, it's obviously an important part of this. With condoms, condom access, STI screening and treatment, and we know, of course, that adolescents not only have high burdens of STI, but they have different ones, so much more chlamydia than older adults, as an example. So that's an important part of the prevention package. PrEP for those who meet the risk criteria. What we've seen, unfortunately, with PrEP pretty consistently with adolescents is that the uptake is modest and adherence is challenging, and long-term retention for long enough to get people through adolescence and into early adulthood has proven to be enormously challenging with daily oral PrEP. We have, and other colleagues have attempted to look at intermittent PrEP for this population, on-demand PrEP, particularly for adolescent men who have sex with men, because the evidence there is pretty compelling that it's so effective. But it's kind of early days with those. So we are left with daily oral dosing as a prevention tool. But I think that is pretty much the primary package. And then obviously for adolescents who inject drugs, it's the same drug treatment on demand, harm reduction services, treatment for positives. But obviously with young people, there's many efforts to try and prevent those transitions to injection. And pretty good evidence actually for some interventions on that front. So it isn't necessarily a different set of prevention packages, but delivery is everything, and access and tailoring to the needs of adolescents. I think the South Africa data tells us that the age mixing challenges there are also a big issue, and the engagement of adolescent boys matters, but for the most part, there's about a 9-year age lag, and women are getting infected from men who are on average 9 years older than they are. So you really also have to reach older men who are at risk. And by older, I mean 20s and 30s. And that actually has been a part of the DREAMS initiative. They are attempting to do that. I think the data are, and the jury is out on whether that's going to have worked.
Great, thank you, Chris. So listen, Chris, we can't thank you enough for such a comprehensive and thoughtful presentation, and for delivering it under less than ideal circumstances, but you just did an amazing job anyway. So we're all very grateful, and a round of applause, even if everyone's on mute. Silent applause to you.
All right.
So much.
All right. Well, thank you very much. And the questions were terrific. I've really enjoyed this. And, I know it's sobering, but I think you have to take the evidence from incidence data as an indicator of where we need to go with prevention.
You're so right. Great, thank you. And there's lots of chat thank yous and fantastic talk in the chat for you. So thank you for a wonderful talk. Take care. Be well, everyone.